So we'll move on to Dr. Ankit Agarwal. He'll be speaking on the low-cost wide field OCT, and I request Dr. Anurag Mishra to please be the discussant for this case.
Good morning and thank you ARC for giving me this opportunity. We know that OCT is now a day-to-day tool for most of the practitioners. Even a single practitioner in a private OPD has a OCT installed. It's like a slit lamp for us now. We use it for screening of various retinal and macular disorders like optic disc edemas, or glaucomas, macular edemas, etc. The most commonly used OCTs are the spectral domain OCTs, but the newer ones are SSOCTs. The spectral domain OCTs had a very strong problem that only a 6 mm or a maximum of 9 mm of scan area was there, while the newer OCTs can take scans up to 12 mm, and there are some wide field OCTs now which are there. They can take up to 18 mm. Thus, the lesions extensions of edema in spectral domain OCTs, it was very difficult to know. For example, in a CSR, huge CSR, the boundaries of which cannot be known in in a single scan. And what happens is that many a times we get our assistants to do the OCT. We don't do it ourselves. So we just see the reports. And when the report comes to us, we cannot distinguish clearly that whether it's a CSR or it's a shallow RD. Also, if perimacular PCV, BRVO, extension of a BRVO, we cannot know. To overcome this, we propose a low-cost technique to increase the scan length. Thus, it will be able to scan most of the area within the vascular arcade in a single scan. For this, we took 10 patients with various indications for OCT screening and did their OCT with two methods. First, a macular scan was performed without the device in front of the eyes. A normal OCT scan length of 6 mm, which is default in my machine, which I am using for this study, that is TopCon Maestro 1 was used. The image was obtained and another scan was taken, for which I took plus 20 diopter dual aspheric glasses. I made the patient wear them, and the glasses had a back string attached so that the glasses are firmly placed in front of the eyes. And the OCT was taken with the patient wearing these glasses. This is how the patient sits in front of the OCT wearing the glasses. And these are the glasses which I used. Now, the scan length of the OCTs which were done with wearing the glasses increased by a proportion of approximately 1.5 times the scan length without the glasses. Now, in a normal fovea, a normal macula, in a ametropic individual, the optic resist to fovea distance is about 4 to 4.5 millimeters. Thus, the scan length with the spectacles covered the area almost all within the vascular arcade in a single radial scan. This is the descriptive diagram how much area is covered using the single radial scan. This above part is the scan with the glasses. Now, an example of OCT is taken. In this patient, we can see that with plus 20 diopter spectacles, a large scan was taken, while without spectacles, only a smaller area was covered. In the case of BRVO, we can see the extension of edema much more than without the spectacle. In an NPDR, we can see that outside the scan area also there are some hard exudates present which can be seen with the OCT. The optics are that the aspheric 20 diopter glasses, they condense the light rays, and thus a wider field of area is obtained. The patients who underwent OCT with plus 20T spectacles had an increased scan length as compared to those without spectacles. This helps in screening of patients of diabetic BRVO, etc., for lesions in the peri-scan area and the perimacular area. The limitations are that this has only been tested on my TopCon Maestro 1. However, basic optics are same for any OCT, so should work in any. But the problem is that the parameters of macular thickness, the RNFL screening, etc., which are done by the OCT software, will not be holding true in this because the OCT software is not configured for this optical change. This innovation helps increase the field of imaging and thus can capture perimacular areas which might have been missed earlier in a single scan without the need for investing a large sum of money on a new OCT with a wider field of area. The cost of these glasses is hardly 1,000 rupees. Thank you.
So that's a nice little bit of innovation that you brought in there. But there are a couple of things that are lurking in my mind, and I can't help asking you. Number one is you probably have not documented what sort of area has been scanned with your technique vis-a-vis the normal wide field OCTs we already have in the market. There should be a comparison. I mean, you have to document it.
So
That's
because it's a single center study, we did it in a private
Yeah.
center. We don't have access to a wide field OCT as of now.
no, you can go theoretical. You can go what they promise and compare it with what, because it's very difficult to document what area exactly are you scanning, because the pictures honestly did not show us much. So we have to see exactly what area they're scanning. The other
So,
thing is,
So what I did was that in the OCTs, when the vascular arcades are scanned, we can see the vessels on the OCT scan. So in few of the OCTs, I could see the vascular arcades in my scan with the glasses. But without the glasses, when I'm doing the scan, I could not see the vascular arcades in the OCT scan.
that's
So-
exactly what I'm saying. Essentially, what you're doing is you are minimizing the magnification that happens at the retina end.
Yes.
Because this machine is not tailor-made to be working with a wide field thing. The beam is the same, right? The concentration of the beam is the same. So since you are compressing it, it is scanning a wider area.
Yes, sir.
Since the machine is not tailor-made to do this job, perhaps it is better to compare it head-to-head with the machines that are already tailor-made to do this job.
I'm already in talks with Qubits actually for this, and they have requested me to send all the data with this, and they are saying that in their next iteration they will give this as a standard accessory, so that a wider field of area can be taken. If a doctor requires. So I've talked to them once. I'll try to finish this research project.
Yeah, so that's what I'm saying. You have to increase your sample size, and also the fact that since you are placing such a high-powered plus lens in front of the eye, there might be a possibility of artifact, because the light rays traveling through such a high-powered lens
That's true,
might
sir.
just...
The signal strength reduces a bit. We can overcome this by using high index glasses, so which are thinner and have less aberration also. And this needs a
And
little
make
bit of
sure they're
research.
perfectly fit, because slight bit of even a millimeter's displacement in front of the eye can have a prismatic effect as well, which will bend the light rays again.
True. That's why we have put the strings behind, and we make it tight so that it does not move with the patient's movements and all. We're trying it, but there's still some research is required in this, sir.
Thank you. Good job.
Thank you, sir.
Yes. Not don't have time on the stage, it has to be done on the side. Next speaker to come.
Thank you, Ankit. Thank you, Dr. Anurag, sir, for that.